Now we'll talk about the skeletal system as far as the articulations go, and so talking about the joints of the skeletal system. So essentially, since the skeletal system, one of its main jobs that it does in terms of its functions is allow for movement of the body in a more efficient manner, we need to talk about the joints as far as their ability to work within the body itself. And so anywhere that we have two bones coming in contact with one another, we're going to have a joint. Anytime that we have bone and cartilage coming in contact with one another, we're going to have a joint. And anywhere that we have bones and teeth coming together, we also have joints as well. When we go to look at joints, we can name them in one of a few different ways. And so we can look at the joint based upon those bony connections, the bone to bone connection. We can look at them based upon how the bone moves, and so what kind of articulation does it give. We can look at it as far as the type of connections that it has between the bones as well. So one of the things that we have to keep in mind when it comes to bones is not every joint that we have moves in the same ability or has the same ability to move around. And so with movement comes a lack of stability. With a lack of movement comes greater stability. And so as we see in the chart here, we have a difference in terms of that mobility versus stability. And so if we want to have more stability within a joint, we can't allow it to move as much. And so that's going to come down to a little bit as far as how the joint itself fits together, and how it's being held together is going to help us to determine what type of movement we have. These ligaments are within the joint itself and allow for control of how much that joint is actually going to move. And so within that, we also need to have a synovial fluid. And so we're going to have a synovial cavity inside the joint that's going to help to essentially lubricate the joint inside. From there, we can move into functional classifications. And so functional classifications are going to look at the joint as far as its ability to move itself. And so does it have a limited amount of movement, or does it have a large amount of movement? And so we have synarthrotic joints, amphiarthrotic, and diarthrotic joints going from the least amount of mobility to the greatest amount of mobility within the joint itself. And it goes similar along with the structural classification as well. And so diarthrotic joints are those synovial types of joints. Those are our highly movable types of joints. Fibrous joints, as we said, are immovable kinds of joints. There's basically no movement in the joint itself. There may be a little bit of a wiggle room within the joint depending upon the particular time in life and things like that as far as the fibrous joint is concerned. And so kind of three general types that we may be familiar with are things like gomphoses. And so this is the joint in between your tooth and your jaw. We have synarthroses. Synarthroses are in between two bones. And so this generally has kind of like a sheet of fibrous connective tissue that goes in between them. And so these are things in the skull like our sutures. We also have them in between our arm bones and our leg bones that are there as well. And then syndesmoses are joints that are, in terms of the bones, they're joined together by ligaments and allow for only a very slight amount of movement. So these types of joints there have very, very little amount of movement within them. And so here we have our joints that we just talked about. And so gomphoses in between the teeth themselves, sutures in between the bones of the skull, and then syndesmoses in terms of the joints are generally in between things like our arm bones and our leg bones. So in between the radius and the ulna, and then the tibia and the fibula in the lower leg. Cartilaginous kind of joints, we have the bones connecting together via a cartilage. And so the two ends of the bones essentially have cartilage wedged in between the two of them. And we see these in places like long bones. And so this is where we're going to have that growth plate, the epiphyseal plate, that's cartilage up until the time where it becomes calcified. And then we have it other places similar to that of our uh, pubic bones. And so inside the pelvis, we have this symphysis pubis. And so we have this structure that lies in between the two bones themselves, and we have that cartilage there. Similar to the cartilage that we have in our intervertebral discs. And so there's not a whole lot of movement there, although we think about our spine as having a relatively large amount of movement per se. There's actually, at the individual level, there's really not a whole lot of movement there. And then we can see at the ends of the bones, we have our growth plate there. And so that growth plate has cartilage within it. And similar to that as what we find in the costal cartilage. And so in between the actual rib and the end of the cartilage that's there. Here on X-ray, we can see those joints as well. And so here we can see those epiphyseal joints running in between the bones themselves. And if there's any kind of damage to them, like we have on this one as well. So if we look there, there's compression of that little joint that's there. And this is going to eventually lead to the closure of that joint, and it's going to stop growing early. Synovial joints are, again, those joints that when somebody says bend your joint or something like that, this is what they're generally thinking about, is a synovial type of a joint. These are highly movable. We have lots of movement generally within them. Some joints have a lot more movement, and so we have things like the Glenohumeral Joint has quite a bit more movement than that of, say, the Temporomandibular Joint, the jaw joint in between your lower jaw and your temporal bone there. We have essentially just a hinge that is there, versus the glenohumeral joint is your shoulder joint, and this allows for quite a bit of movement. We've got a large range of motion that's there. Our elbow joint, our knee joint, our ankle, our wrist, all of which are synovial joints. And with synovial joints, there's a lot more to them in terms of the structures that are involved. And so when we look at a synovial type of a joint, we have a capsule that surrounds the joint, and that capsule is going to essentially hold it, all the structures inside there. And so this has everything inside the joint itself. And so there's a cavity that's inside there, kind of this purple area that's in there. And that cavity is then filled with synovial fluid. And so there's a lubricating factor to the inside of that joint, which is the synovial fluid itself. In between the two bones, we're going to have articular cartilage so that the bones aren't rubbing bone on bone in between the two. And then we're going to have varying degrees of ligaments that are going to be able to hold the joint itself together, or at least limit the amount of movements that's there. Different joints may have even ligaments crossing in between the joint and helping to hold it together. Similar to what we have here in this picture, where we have a case of a person who has torn their ACL. And so there we had a situation where a ligament inside the joint has been torn, and it leads to all kinds of swelling. And so there's no doubt that something has been damaged inside there. And so with an ACL tear, oftentimes you see an awful lot of swelling of the knee itself. And so it has blood supply surrounding the ligament, not really going to the ligament. And so if anything causes damage to the ligament, oftentimes there's going to be damage to the blood supply as well. And here we see it on MRI as well as a repair. And so up here, we can see that the ligament itself is torn in half. There's really nothing left of the ligament itself. And then on the bottom one, we have a normal looking one where it's going to be able to limit that motion in between. And same thing here, we have a normal, and then we have a rupture on the upper one. In addition to having things like ligaments and synovial cavities and synovial sacs and things like that in and around a synovial joint, because these joints are highly movable, we need to have some protection there. And so the protection oftentimes comes in the form of bursa. And so those bursa are like little tiny fluid-filled paddings. And so they're almost like a little pillow in a sense, that's there. And that little pillow stops from excess rubbing of ligaments and tendons against bones, or ligaments and tendons against other muscles. It all kind of depends on where exactly they are. But in generally, they're there for protection of the structures that are in and around the joint itself. Oftentimes, those bursa are kind of padding things like tendons that may be kind of coming across the joint itself. That's there. And those tendons are associated with muscles, and those muscles pull on the tendons. The tendons then pull the bone, and that allows for the movement of the joint itself as well as stabilizing the joint. They're going to help to limit that motion when we want to kind of keep a joint from moving. So just like if you were to carry a bag in your hand and you are holding it, you don't want your wrist kind of going back and forth and back and forth. And so those tendons, as the muscles contract, allow for your wrist joint to become more stable. So here we have a knee that has bursa within and around it. And so we have these infrapatellar bursa. We have a prepatellar bursa. These ones are often, either one of them are oftentimes damaged when somebody falls. If they fall down on their knee, oftentimes this infrapatellar one is potentially damaged. If they fall right on their patella, they may cause some inflammation on the prepatellar bursa itself. On the posterior side here, we have another bursa that's common to actually become swelling as well. And even the joint has the potential within that synovial sac to start to kind of bulge out. And so you can get what's called a Baker cyst at the back of the knee there, which is just the synovial sac itself has been kind of stretched out a little bit. So synovial joints are named based upon their movement that they're able to do. And so within the joint itself, they may be able to move on a single axis. And so we have uniaxial types of joints. We have biaxial joints. These can move in more than one direction. And so a uniaxial is kind of like a hinge, and so kind of like a door. It just simply moves back and forth and back and forth. And this is something like our knee. A biaxial joint can move in at least two planes. And so it has the ability to move not just in a sense kind of back and forth, but then side to side. And so it has that ability to move in at least two planes that are there. And then we have multiaxial. Multiaxial have the ability to move in both the X, Y, and the Z planes. And so we have a large amount of motion that is there. Within synovial joints as well, the different types of uniaxial, biaxial, or multiaxial types of joints have individual names to them. And so we have things like planar joints. These are where they slide past one another, they kind of glide along one another. We have hinge joints. These are similar to, as the name implies, they're like a hinge. They just simply move back and forth. We have pivot joints, where we can kind of rotate around in a particular point. We have condyloid types of joints. These are now biaxial joints. This is kind of like putting two saddles together, and so it can move forwards and backwards and side to side. On there, this would be kind of like a universal type of a joint. We have saddle joints are similar to those condyloid types of joints in terms of the structure that kind of pulls them together. And then we have ball and socket joints, which are our multi-axial joints. These are our most movable of all the joints that we have. So seeing them in action here, we have planar types of joints where they're going to kind of slide past one another. These are common in places like the wrist and the ankle, also in parts of the vertebrae. We have a planar type of a joint in between part of the vertebral structures that are there. our saddle joints and our condyloid joints. The saddle joints are like putting two saddles on one another, and then our condyloid joint is similar to having um, a rounded surface going onto another rounded surface, and so they have that kind of convex curve to them. Hinge types of joints, things like our elbow, our knee, but the elbow is not just a hinge type of a joint, because it doesn't just, at the elbow, we don't just do flexion extension in terms of hinge, we're also going to be able to do some pivoting. And so we have a pivot type of a joint there as well, which is also what we see up in the very top of the spine. And so as we turn our head from side to side, we're going to do a pivot type of a motion, and the first two vertebrae are going to pivot around one another. And so we're going to have that type of movement that is there. Ball and socket joints, things like our hip, things like our shoulder, both of those have a ball and socket type of a joint, and they allow for quite a bit of range of motion. But again, your hips and your shoulders don't necessarily have the same degree of mobility, and so depending upon the way that the joints actually come together dictates the amount of movement that's really going to be there. So we said that joints are named oftentimes by the bones that they are articulating with. And so we have things like our temporomandibular joint. This is between the temporal bone and the mandible. We have things like our sternoclavicular, and so between the sternum and the clavicle, and so we can tell where it is right away. Glenohumeral, again, this is our shoulder joint. But then we also have more common types of terminology that are used for joints as well, like the elbow and the knee and the hip, are kind of more accepted terms for some of the joints that are there. But that being said, at the elbow we have the ulnohumeral joint, which is the actual hinge joint there for the elbow. And then same thing for the hip. We have in between the femur and the acetabulum. So here we can see the temporomandibular joint in between the mandible, the lower jaw, and that of the temporal bone. And it is a synovial type of a joint. So it does have a synovial sac with inside there. There is a little bit of a disc in between, and this is what kind of gives some people some problems with clicking of the jaw and things like that, as that may wear out. From there we have those joints of our vertebrae, and so we have the gliding joints here in between the superior and inferior articular processes, and so those allow them to kind of slide back and forth between one another. We have our sternoclavicular joint in between the sternum and the clavicle itself. And so there's very little movement in this joint, but it does pivot just a little bit in between there as we raise our arm up and down. Glenohumeral joint. So we have our ball and socket style joint here. Each one of the pictures that we've seen of the joints themselves, you should have a pretty good idea that they are very well held together by a lot of ligaments. And so they're really controlled as far as their ability to move. And that's what happens when we sprain a joint, is we've torn some of those ligaments that are there. And with the glenohumeral joint, we can even then see that we also have a large amount of bursa as well. Elbow joint is a fairly complex joint, and so it does have the ulnohumeral joint in between the humerus and the ulna, but then we also have the radial ulnar joint in between the radial head and the ulna itself, and we also actually have in between the radius and the humerus. And so we have multiple joints there within the elbow, all held together by a large amount of ligamentous structure, as well as relatively powerful muscles. Here we have our gliding joints of the wrist. And so each one of these bones is going to kind of wiggle past one another. And so they're going to kind of jiggle and wiggle as we move our hand back and forth. And there's not a lot of movement there, but there is movement. The majority of, in a sense, the wrist movement is coming from the radius and the carpals themselves. And so the radiocarpal joint that is there. The hip joint is another ball and socket joint. And so we have the coxal joint or the hip joint. Once again, lots of ligamentous structure that helps to hold it together and is holding that hip up into the socket itself. And so the ball part comes from the femur, the head of the femur here, and then the socket part comes from the acetabulum. And so we have these structures that are there that are going to allow for that movement that's there. But as you can see, that joint, the head goes a lot further into the joint itself, into the socket, which limits the amount of movement that the hip can do compared to that of the shoulder. Once again, the knee, we have a very complex joint again, not quite as much so as the elbow is as far as movements go. We have a lot less rotational movement that occurs within the knee compared to that of the elbow. And so we don't do as much of that rotating process down here in the joint itself. That's there. But there is a tiny bit that does occur between there. Primarily the knee joint is between the femur and the tibia. The fibula over here is a non-weight bearing bone. So the femur does not actually push down on the fibula whatsoever. And so it doesn't have a whole lot of articulation within the knee joint itself. It's just kind of going, the tibia actually comes out. Let me erase that. So the tibia kind of comes out here like so, and looks something like that. And then the femur is like so on top of there. So the femur doesn't actually even touch the fibula. The fibula is just there within the knee joint where it ends. It doesn't have any kind of articulation within the joint itself. The limiting motion for rotation comes from both the ACL and the PCL. And so both of those ligaments are there. We can kind of simulate the ACL and PCL by crossing our fingers. And so if you take the second and third fingers and cross them over one another, they pretty much do the same crossing over that the ACL and the PCL do as well. And then we have medial and lateral collaterals also. The ankle joint is a very complicated joint as well. Primarily when we talk about the ankle joint, we're talking about between the tibia and that of the talus. And so the talocrural joint is the joint that is there where we're going to be able to move our ankle forwards and backwards and side to side. But the ankle bones themselves continue on throughout all of this region in here, including the fibula and the tibia, and then the talus down below. And what it ends up being is that if we were to look at it from the front, we have kind of the fibula there, and then the tibia comes down like so, and then the talus comes up like so, like this. And so the fibula is pushing in this way, the tibia is pushing in this way, and it kind of grabs onto that, that talus there down in the ankle joint itself. And so it kind of grabs onto that as it sits there and allows us to have that motion that we're going to have in the ankle itself. So when we look at joint movements for the different movements themselves, these come into play when we start to look at the bones in terms of the muscles, when it comes to the different motions that a muscle can perform or what it causes the joint to do comes down to these different movements of the joints themselves. And so we'll run through some of the definitions of those here. And so we have abduction and adduction. Anytime that we have an abduction of a joint, we're taking it away from the body. And so we can see that with abduction here, it's going away from the core of the body. Versus adduction is bringing it back in towards the core of the body. And so this can be done by things like the hip and the shoulder, but it can also be done by the fingers and toes and wrists and ankles. From there, we can do flexion and extension. So lots of joints and muscles do flexion and extension. And so by definition, if we are flexing a joint, we're decreasing the angle of the joint. And so we're decreasing the angle that is there in between the joint itself. If we're doing extension, we're increasing that angle. And so we're increasing the angle of that joint. And so for normal anatomical position, the elbow starts out at 180 degrees. And then as we go into flexion, we hit 90 degrees and so on, and get lower and lower and lower from there. Hyperextension brings the joint typically beyond that 180 degree point and causes it to go beyond anatomical position. So we can see here with hyperextension of the neck, we've gone beyond the normal anatomical position with the joint itself. And that can also be done in things like the hip. We can hyperextend and things like that. We can do that with the shoulder joint. We can go into hyperextension and so on. From there, we have things like rotation. So the head and the neck can do rotation. The torso can do rotation on those vertebrae. But then we can also do the rotation in things like the shoulder joint and the hip joint as well. So we can turn the toes outward, we can turn the toes inward, and so we can have rotation of the hip into medial or lateral rotation, or that of the shoulder as well. The shoulders can continue to do other things as well. So we said that it was a multi-axial joint, and so we can do depression and elevation. And so depression is basically getting them into anatomical position. Elevation is shrugging the shoulders, bringing them up. The ankle has the ability to do a little bit of special movements in terms of their names, as far as their names are concerned. And so we have plantar flexion and dorsiflexion. And so plantar flexion, the bottom of the foot is referred to as the plantar surface. So when we point our toes downward, we're doing plantar flexion. The dorsum of the foot is the top of the foot. So when we raise the toes up, we're doing dorsiflexion. The ankle can also do a series of movements in terms of rolling it inward and rolling it outward. And so this gives us either inversion or eversion. And so those two rollings that occur there. When somebody like sprains their ankle, what we generally think of as being in terms of a sprained ankle is an inversion sprain. That's the more common of the two, but somebody certainly can eversion sprain their ankle as well. There. Sometimes, depending upon who you read or the source that you're looking at, inversion is also referred to as supination, and eversion is referred to as pronation. Those same two movements we find up here in the forearm. And so the forearm can do pronation and supination. Anatomical position puts the forearm in supination. And then to point the palms backwards, we go into pronation. You can also think of supination as being the movement that you would need to have your forearms in if you wanted to hold a bowl of soup. And so you'd have to have palms up to do the holding of the soup bowl. And so supination and the soup bowl go together. In the hand, the special movement that we're able to do is opposition. And so we can do opposition of the thumb, meaning that the tip of the thumb can touch the tip of each individual finger. And so you can touch the tip of your thumb to each of the other fingers themselves, all the digits from 2 through 5. And then lastly, we have the jaw. And the jaw not only does elevation and depression, similar to that of the shoulders, it also has the ability to do protraction and retraction. We can essentially do an underbite and an overbite with each of those movements themselves. And those are all chewing types of motions. We grind our food and move our teeth forwards and backwards as we grind the food potentially. And that causes that to move forwards and backwards. And then elevating and depressing the jaw allows us to chew up and down and grind the food up that way as well. And that'll do it for our joints.